This is part 2 of a two-part series on anesthesia pharmacology keyword review, covering the American Board of Anesthesia keywords from 2020 as part of our 2021 keyword review. My name is Randy Schell, and this is part of the University of Kentucky Department of Anesthesiology's didactic series. Now, in part 1, we covered the pharmacology of local anesthetics, neuromuscular blocking agents, opioids, and IV anesthetic agents. That is the key words that were present and published by the American Board of Anesthesia in 2020. And now we're going to move on and cover the key words related to inhaled anesthetics, pharmacokinetics, and some miscellaneous topics. I want to remind you that our YouTube channel has comprehensive reviews that go back decades on pharmacology review. This is designed to cover the keywords from the ABA 2020. So let's look at those. Inhaled anesthetics, nitrous oxide, closed spaces. We know that they move into air-filled spaces and make them bigger. And the B after it stands for the basic content outline. Volatile anesthetics, what do they do to ventilation? We pant with low tidal volume and respiratory rates. Vaporizers, how do they work at altitude? Pharmacokinetics, context-sensitive half-time, cytochrome P450, and ultrarapid metabolizers, especially how it affects codeine and morphine. Pharmacodynamics and dose-response curves, and then some miscellaneous topics like monitoring SSEPs and how our anesthetics affect them, Glycopyrollate and other anticholinergic side effects, anticoagulants and where they work and their effect on PT and PTT, Citrate Toxicity and how it binds calcium, Diuretics, how they work, where they work, Furosemide, side effects, Magnesium effects, Nitric Oxide and how it works, NSAIDs and their renal effect on reducing prostaglandins and renal blood flow, Digoxin Toxicity and how we treat it, Magnesium Toxicity and some of the signs of it, Organophosphate Poisoning, the diagnosis, and Tramadol, how it works at mu receptors and at two other areas that we'll talk about. Gaps in knowledge in 2020, there was one gap related to inhaled anesthetics, that they have an increased pharmacodynamic effect in children with cerebral palsy. Apparently this was missed by a large number of people taking the exam, in-training exam in 2020. Let's move on to our first keyword, nitrous oxide, closed spaces. We know that nitrous oxide is 35 times more soluble than nitrogen, which is what air is mainly made of, and so air-filled spaces will rapidly get larger and expand in the presence of nitrous oxide. Air embolism, a pneumothorax. A pneumo will double in 10 minutes and triple in 30 minutes in its size. You can see how a tension pneumothorax will develop quickly from a regular pneumothorax in the presence of nitrous oxide, potentially that is. Bullous cysts, patients with bad COPD and big old cysts, those cysts can fill with nitrous oxide and they can burst and cause a pneumothorax. Pneumocephalus, when the dura is being closed at the end of an operation on the brain, air is trapped underneath it. If the dura is closed and airtight and nitrous oxide was being administered, it could fill that airspace and cause a tension pneumocephalus. Middle ear, if the eustachian tube is not open and a graft, for example, was put on the middle ear tympanic membrane, and you could see how the pressure could build up in that air-filled middle ear and blow off that graft that was just put on. Sulfur hexafluoride gas, or SF6, is used occasionally during retinal detachment procedures, injected in the back of the eye. That gas bubble stays there for an extended period of time, and we will avoid nitrous oxide for weeks, 4 weeks or more sometimes, after sulfur hexafluoride because of the worry that sulfur hexafluoride gas bubble could expand in the presence of nitrous oxide and raise intraocular pressure. The cuff of our endotracheal tube, if you're giving nitrous oxide to a patient, the cuff is up, that cuff filled with air can expand itself and the pressure can rise in it. We know that the pressure should be less than 30 centimeters of water because of the risk of that cuff reducing capillary blood flow in the trachea. And then bowel distension. Nitrous oxide can increase bowel gas volume very quickly, and in a patient with bowel obstruction, this would especially be detrimental. The next key word is volatile anesthetics and their ventilatory effects. Patients breathing a volatile anesthetic, for example, through an LMA without any other opioids or other drugs given, they will hypoventilate and their CO2 will go up in their blood, and the apneic threshold will be higher. So if you're ventilating, if you're administering a volatile anesthetic to a patient who has an LMA down and they're breathing spontaneously, and their end tidal CO2 is 50, their respiratory rate is 25, and their tidal volume is only 200, that is pretty characteristic. And if you take the bag and try to breathe them below that end tidal CO2 of 50 down to 35, for example, they will not breathe because their apneic threshold is high. And until that CO2 builds up in their blood back up closer to the 50, they start breathing again on their own. That is the demonstrated effect of an increase in apneic threshold. Patients are panting under volatile anesthetic. The respiratory rate is high, like the 25. The tidal volume is low, like sometimes even down to 150, 200 mils per breath. And the ratio of dead space over tidal volume, which normally is about 0.3, with dead space, anatomic dead space, being about 1 mil per pound or 2 mils per kilogram, or about 150 mils total, divided by tidal volume. If it was 450 mil normal tidal volume, you can see that about a third of every breath goes to dead space. If your tidal volume decreases to 300 mils now, you can see how the anatomic dead space stays the same at 150, but now the ratio is 150 over 300, and more is going to dead space. Instead of 30%, now 50%, and CO2 rises. Under a volatile anesthetic, the ventilatory response to hypoxia is profoundly affected, even by very low concentrations of volatile anesthetics like 0.1 mmHg. So in that carotid body, the volatile anesthetic, you can think of it as inhibiting the hypoxic response, and when a patient's normally hypoxic, they should hyperventilate. If even small amounts of volatile anesthetic are present, they do not hyperventilate normally. The ventilatory response to carbon dioxide is also affected, not as much as hypoxia, but at 1 to 1.5 mmHg, it's essentially absent. That is, if carbon dioxide went up in the gas that a patient was breathing, normally they would hyperventilate. In the presence of a volatile anesthetic, they do not hyperventilate similarly. Volatile anesthetics are bronchodilators, iso and sevo, and DES, all of them. DES is an upper airway irritant. And volatile anesthetics attenuate hypoxic pulmonary vasoconstriction. Remember, in part 1, propofol is a bronchodilator also. Propofol did not attenuate the hypoxic pulmonary vasoconstriction. It actually potentiated. Now, vaporizers at altitude and misfilled vaporizers are two common keywords on ABA in training examinations. So let's take a moment to go through, first of all, vaporizers at altitude. A desflurane versus isoflurane vaporizer. The desflurane vaporizer, if it's calibrated at sea level and set at 1 mmHg or about 6%, it's going to deliver 6% at whatever altitude you're at. So let's assume that you have that DES vaporizer set at 1 mmHg, 6%, and at sea level, the atmospheric pressure is 760 millimeters of mercury. So if DES is 6% of that, that means that DES is 46 millimeters of mercury partial pressure. And so the DES could be expressed as 1 mmHg equal to 46 millimeters of mercury, or 6% at sea level. DES 6% now, if you took it up to 7,000 feet elevation, where the total atmospheric pressure is only 600, then that is 36 millimeters of mercury, which is less than it was at sea level. So that vaporizer is giving a constant percentage, and if you want to deliver a partial pressure, which is the important part for MAC, you would have to increase the dial percentage to deliver that same partial pressure. Otherwise, you would underdose the patient. So if you go to altitude with desflurane, you're going to have to turn up the dial a little bit to deliver the same partial pressure to a patient. Now, an isoflurane variable bypass vaporizer is, if it was calibrated at sea level and set at about 1 mAh or 1.2%, it actually changes its output depending upon the ambient pressure. So that isoflurane vaporizer calibrated at sea level and set at 1 mAh or 1.2%, at sea level 1.2% of the total atmospheric pressure 760 equals 9 millimeters of mercury. So 1 mAh of isoflurane can be expressed as 9 millimeters of mercury. The isoflurane vaporizer with the dial set at 1.2%, while you're up at that 7,000 feet now, where the total atmospheric pressure is only 600, what happens is there's less pressure forcing down on the liquid in that variable bypass vaporizer, and it actually more goes up into the gaseous phase, and instead of delivering 1.2%, it delivers more than 1.2%. And basically you can think of it as no dial change needed because it delivers a constant partial pressure to the patient. Now, compare that concept with a misfilled vaporizer. If I took isoflurane and put it in a sevoflurane vaporizer. Now, isoflurane's vapor pressure is 240 millimeters of mercury and its MAC is 1.2%. Sevoflurane has a lower vapor pressure of 160 millimeters of mercury and its MAC is about 2%. And you set the vaporizer at 2%. So you have a sevoflurane vaporizer, you think it's sevoflurane, but it's actually isoflurane inside, and you set it at 2%, thinking you're delivering 2% sevo. The vaporizer would actually deliver more than 2% because the vapor pressure of iso is higher than the sevoflurane, and the delivered MAC would be much greater than the expected 1 MAC of sevo. And these are two concepts that you may have to go over several times to fully understand, but they're important ones to understand how vaporizers work and MAC as a partial pressure and vapor pressures. The next keyword is context-sensitive half-time, and that by definition is the time required for the central compartment drug concentration to fall by 50% as a function of the duration of an infusion. That is, you're infusing some drug for an extended period of time and then you shut it off after 1 hour, 2 hours, 8 hours, 10 hours. How long is it going to take to drop its concentration by 50%? And if you look at the graphic of intravenous anesthetics like Valium, thiopental, midazolam, ketamine, propofol, and etomidate, you can see that propofol and ketamine and etomidate have kinetics that are favorable for infusions, because if you shut it off even after 6 to 8 hours, you can see that there's not a big long prolongation of duration of its time to drop 50% of its drug concentration in the central compartment, as opposed to Valium. You start a Valium infusion and you can see how long it would take. After a very short period of time, it's going to take a long time after you've infused it, after shutting it off, for it to drop 50% in the central compartment. Not a great drug for infusing. And on the right is opioids, and showing example of fentanyl versus sufentanil and remifentanil. And you can see remifentanil has a very flat context-sensitive half-time and a very short one, minutes, such that even if you infuse it for up to 10 hours or longer and you shut it off, it has a predictable and very rapid drop in its concentration. So remifentanil, even in long duration infusions, doesn't change its context-sensitive half-time much. However, don't forget that in elderly patients, remifentanil dose, the amount that you give, should be decreased like other opioids by about 50%. Sufentanil, very favorable characteristics also for infusions, but look at fentanyl, not very favorable characteristics for infusion. So there are some other considerations too when you're infusing a drug. Are any metabolites building up? For example, midazolam has metabolites that can build up over time, and in the ICU, if you infuse midazolam for an extended period of time, that could affect awakening times. Pharmacodynamics, remifentanil, I already pointed out that the dose should be decreased 50% in the elderly. Even though they're metabolizing it rapidly, they tend to be more sensitive. The next topic is cytochrome 450 and ultra-rapid metabolism. And let's first talk about phase 1 and phase 2 reactions in the graphic at the top right. And at the red star, you can see a phase 1 or oxidation reaction where a drug administered is metabolized to something by oxidation or reduction or hydrolysis to something that's polar that can be then excreted rapidly. It's a charged molecule and then can be excreted. So that's a phase 1 reaction, as opposed to, on the top right, a conjugation reaction where you attach a sugar to a drug so that it can be excreted, for example, in the biliary system or in the kidney. That's a phase 2 reaction. So we're talking about phase 1 reactions when we're talking about the cytochrome system right now. Cytochrome P450, especially the CYP2D6 metabolism enzymatic system, is very commonly used in with the drugs that we utilize perioperatively. And there's some drugs that can affect this enzymatic system. For example, anticonvulsants like Dilantin and carbamazepine or Tegretol, they actually induce these enzymes or ramp them up so they're ready to metabolize other drugs more rapidly. Some of the psychiatric drugs, SSRIs, HIV treatments can inhibit the CYP2D6 system. And someone, for example, on an HIV drug where this cytochrome system is inhibited and you give them midazolam, they're not going to break down the midazolam as fast and they have more effect for the same amount of drug administered. Now to the point that was in the key word is, can you have variations in this cytochrome system? And what does ultrarapid refer to? Now, in the graphic on the bottom right shows codeine as a prodrug is metabolized to morphine. That's what makes it active. Codeine alone is not effective as an analgesic. It is metabolized by the CYP2D6 system to morphine. If this CYP2D6 activity, the enzymatic activity, is normal, codeine is broken down or metabolized to morphine and it has analgesic effects. If you have a poor metabolizing system, you're born with it genetically, and 7 to 10% of Caucasians do, and you're administered codeine, you're not going to break it down to morphine like others, and it's not going to be very effective, codeine as an analgesic. And there are other people that are genetically ultra-rapid metabolizers. That's where in the bottom right, where they have lots of the enzyme around, you give them a standard dose of codeine, they're going to convert it to a high amount of morphine and have much more effect because of their ultra-metabolism to codeine into morphine. Weaker opioids, some are metabolized to more potent opioids. Codeine was one example, tramadol is another, hydrocodone, dihydrocodone, oxycodone to morphine, hydromorphone, oxymorphone, methadone. Not significant effect with fentanyl, remifentanil, and sufentanil. So our synthetic opioids that we use in the operating room, not so much effect of this CYP2D6 system. The concept again is that if these enzymes are ramped up, you're going to get more bang for your buck from codeine. If they are poor metabolizers, the patient, and you give them codeine, they're not going to convert it to morphine and you're not going to get an analgesic effect. Pharmacodynamics and dose response curves was the next keyword. Let's look at the graphic first, where we have on the y-axis a response and on the x-axis the log drug dose or concentration. And you can see that as you compare A versus B, it takes more drug to have a response. So potency is the relative dose of two drugs, fentanyl being more potent than morphine, and drug A in this graphic being more potent than B. But efficacy refers to the ability of the drug to produce a specific clinical effect or physiologic effect. And you can see that B, even though it's less potent, it takes more drug to have a response, it can reach a higher response. It's more efficacious than is A. The difference between potency and efficacy. The next key word is SSEP monitoring and anesthesia effects. SSEPs are often utilized during back surgery, and in the case of back surgery, often the stimulus is applied at the ankle to a nerve and recorded at multiple areas below the spine and above the spine and up on the head. And when the signal is applied, a stimulus to the ankle nerves, there's a period of time before it reaches via nerve transmission to the next level, and that time is called latency. And the height of the signal that's recorded is called the amplitude. So the amplitude and latency are two important factors with SSEP signals. If the cord becomes ischemic and you stimulate the nerves in the ankle, you can see how that signal would not reach up to the subcortical or cortical areas. Or if it does, it may have a decreased amplitude and take longer to get through. Our anesthetics in general, across the board pretty much, make the amplitude lower and make the signal take longer to get through. And the exceptions are ketamine and etomidate, which actually make the amplitude higher. And if you're having problems getting signals, you can substitute some of your anesthetic with ketamine or an etomidate infusion and make the amplitude higher and easier to record. Neuromuscular blocking agents, if you're just monitoring SSEPs, actually are helpful because they eliminate background myopotentials and make it easier to see the signal get through without all the background noise. However, if you're using motor evoked potentials, obviously you can't paralyze the patient or you're not going to get a motor evoked potential. An anesthetic for SSEP monitoring is classically a TIVA anesthetic like propofol, remifentanil, although low-dose volatile anesthetics with neuromuscular blockade can be used for just pure SSEP monitoring. SSEPs monitor the posterior columns, the sensory columns, and you can have anterior injury to the spinal cord and not be picked up by SSEP. A patient wake up and not able to move because the anterior cord wasn't being monitored and it was damaged, but still be able to feel proprioception and the posterior cord intact. That's what you were monitoring. So the anterior spinal artery syndrome actually refers to damage to the anterior spinal cord and motor effects. And if you just had pure injury to the anterior spinal cord, you could have potentially no changes in SSEP because it's monitoring the posterior columns. The motor evoked potentials monitor the anterior columns and are frequently combined with the SSEP so that you get both anterior and posterior monitoring. Subcortical responses, that is the ones below the head, are more resistant to the non-surgical factors like our anesthetics than do corticals. So if you turn up your volatile anesthetic, they have more effect on the cortically recorded signals than the ones down near the back and the legs. The next two keywords, there was two of them in 2020, related to anticholinergic side effects. Glycopyrollate side effects was a second one. So let's focus in on what anticholinergics can do to the body in the graphic on the far right. They can make our eyes blurry, our mouth dry, constipated, stop sweating, and so patients can, if they can't sweat, they can become overheated, not able to urinate or empty their bladder, and their heart rate goes up. And if it is able to cross the blood-brain barrier, that anticholinergic, it can mess with the acetylcholine system in the brain. And scopolamine is the classic one here, causes drowsiness and dizziness and confusion. And even a scopolamine patch can do that sometimes in patients, like an elderly patient. So CNS toxicity, one of the first side effects we'll focus in on. Atropine and scopolamine are tertiary amines, uncharged amines. They can cross the blood-brain barrier as opposed to glycopyrrolate, which is a quaternary amine, which is a charged amine and doesn't cross the blood-brain barrier. So the CNS effects are absent with glycopyrrolate, but with the tertiary amines, atropine and scopolamine, you can get dilated pupils and central anticholinergic syndrome, where after a patient has had atropine or scopolamine, they're confused and somnolent and sedated, and they're delirious, and you come in and assess them and realize that it's scopolamine related, and you can give them a centrally acting anticholinesterase, physostigmine, which does cross the blood-brain barrier, unlike neostigmine, and can reverse the effects. Patients' heart rates can go up. Atropine does that more than glyco, which does it more than scopolamine. And as I mentioned, suppression of sweating is associated with anticholinergics, and body temperature can go up. Lower esophageal sphincter actually relaxes, and physiologic dead space in the respiratory system increases. And these are some of the side effects of anticholinergics. The next key word is anticoagulants and their effect on different laboratory measures, PT, PTT, for example. So let's focus in on warfarin first, and if you look at the graphic on the far right, you can see that warfarin works in multiple parts of the coagulation cascade, inhibiting the synthesis of the vitamin K-dependent clotting factors 2, 7, 9, and 10, and also, by the way, the anticoagulant proteins, protein C and S. We monitor the prothrombin time and the INR for patients who are taking warfarin. For example, those are taking warfarin who have atrial fibrillation and reducing the risk potentially of stroke, embolic stroke. Low molecular weight heparin or enoxaparin or Lovenox, how does it act? It's not shown in the graphic here, but if we focus in the middle of the graphic on 10A, that is the major part where low molecular weight heparins act. They bind to antithrombin 3, accelerates the antithrombin with selective inhibition of the clotting factor 10A. Now, antithrombin plus low molecular weight heparin doesn't inhibit thrombin like our unfractionated regular old heparins do. And we can monitor anti-factor 10A activity, don't do that very commonly, but we don't monitor PT, PTT, or INR for enoxaparin or low molecular weight heparin therapies. Heparins are unfractionated ones, bind to antithrombin 3, activate it, and then that combination of the heparin with antithrombin 3 inactivates thrombin and 10A and other proteases, and we know that we monitor the PTT for heparin's effect. There are some newer anticoagulants, rivaroxaban, which is Xarelto, apixaban, which is Eliquis, and they are factor 10A inhibitors. And if you look at the graphic, you can see factor 10A inhibitors coming in there, inhibiting 10A, and we don't use routine monitoring. This is one of the benefits, potentially, of someone being switched from warfarin to one of these who has atrial fibrillation. Factor 10A is inhibited, but there's no routine monitoring necessary. Dabigatran, in the graphic on the far right, shows it as a direct thrombin inhibitor, or DTI. Pradaxa is another name for that. And there is an antibody-related reversal available that can be given in patient who is taking Pradaxa, for example, gets in a car accident, is bleeding a lot, and you want to reverse it. There is an antibody reversal available. There is no routine monitoring necessary for dabigatran or Pradaxa. The next key word is citrate toxicity and the treatment of such. Citrate binds calcium, and if you look at the graphic on the far right, you can see why. Citrate being very negatively charged and calcium being positively charged, that electrostatic interaction. Citrate binds calcium, and it's the anticoagulant in stored blood products. And many people forget that it's not only in packed red blood cells, but there's even a lot more apparently in FFP and platelets. So all of our blood products, FFP, platelets, and packed red blood cells, have citrate, and citrate binds calcium. Now, what happens to the citrate when it's administered to a patient? It is metabolized by a functioning liver in the TCA cycle to carbon dioxide. And then if you have the normal enzymatic function of your carbonic anhydrase, it's converted to bicarbonate. So citrate ultimately becomes bicarbonate, similar to what lactate with a functioning liver becomes bicarbonate. So lots of citrate administered to someone through blood products, potentially their liver could convert it to bicarbonate and alkalinize a patient. Citrate toxicity is really quite rare, and you have to be given blood products very rapidly, large amounts of FFP, large amounts of packed red blood cells, and the toxicity is the result of hypocalcemia. If you're hypocalcemic, you can vasodilate and be hypotensive. Your heart doesn't work as well. Your pressures inside your heart go up because it's not contracting as well. Your CVP and end diastolic pressures, your pulse pressure narrows. You can get tetany of muscles and even laryngospasm. Schaffte's sign is where If you tap on the facial nerve just in front of the ear, you can get spasm of the orbicularis, the distribution of orbicularis oculi of that facial nerve. And the Trozosin, which is basically if you blow up a blood pressure cuff on an arm, the arm gets ischemic, carpal pedal spasm occurs, the hand contracts. And so Chopsticks and Trozosin are signs of hypocalcemia. Dysrhythmias can occur from hypocalcemia, coagulopathy from hypocalcemia, and QT interval can start to prolong as you get hypocalcemic. So citrate toxicity should be equated with hypocalcemia and what hypocalcemia causes. So the treatment is IV calcium. The risk is if you give blood products very rapidly, like FFP, or if the patient's very cold and their liver's not metabolizing citrate well, or liver dysfunction, or even the anhepatic stage of a liver transplant where you're pouring in blood products that don't have a liver and citrate can build up. Remember that citrate is also present in light blue top blood collection tubes, and it's present in continuous renal replacement therapy in patients who are on that in the ICU and brought down to the operating room. If they were still on it or recently had some or still in the lines, you could see how a patient could get citrate-related issues and hypocalcemia. Diuretics and mechanism of action is the next key word. And these are color-coded to help correlate with the picture graphic on the far right. And we'll start with the thiazide diuretics like hydrochlorothiazide in green. And you can see that the thiazide diuretics work in the distal convoluted tubule. They're not very effective when the kidney's not working well, when the glomerular filtration rates are very low and we have to use diuretics like Bumex. Thiazides can cause dehydration, they can cause hypokalemia. It's not uncommon preoperatively to see someone who's taking hydrochlorothiazide for long periods of time to have potassiums of like 2.8, 2.93, metabolic alkalosis, and some specific to thiazides like hypercalcemia and hyperuricemia. Acetazolamide or Diamox is shown in the lighter blue, and you can see that its action is on the proximal renal tubule and it inhibits carbonic anhydrase. And that enzyme is needed for bicarbonate metabolism and formation. And basically, if the proximal renal tubule carbonic anhydrase is inhibited by Diamox, you can't absorb bicarbonate. And so you pee bicarbonate. And so you'll pee a very alkaline urine, and if you're peeing bicarbonate, you're going to get more acidotic in your body. And so a metabolic acidosis ensues, and you also can get a loss of potassium and sodium. But it's this metabolic acidosis that is common in patients taking Diamox if you draw blood gas from someone who is on one. Why would you be taking Diamox or acetazolamide? Glaucoma, occasionally in older treatment for glaucoma. It reduces aqueous fluid production. And those who are going up to high altitude sometimes will take it prophylactically to help them keep hyperventilating, induces an acidosis and allows them to continue to hyperventilate and shift the oxyhemoglobin curve favorably. So getting ready for high altitude and avoiding high altitude sickness is what a Diamox may be used for. Spironolactone is shown in the purple, and you can see where it acts is in the distal tubule. It's an aldosterone antagonist. And aldosterone helps you reabsorb sodium and excrete potassium. So if you inhibit that, you're obviously not going to excrete as much potassium, and these potassium-sparing diuretic can actually cause hyperkalemia. So a side effect of aldactone, spironolactone, is hyperkalemia. It's a weak diuretic, sometimes used in patients with heart failure and edema secondary to liver failure. Lasix or furosemide and its side effects is the next key word. Lasix, when you give it, has its onset within minutes, approximately 5 minutes, maximum in 20 to 60 minutes, persists for several hours, and it is inhibiting sodium and chloride reabsorption in the ascending limb of the loop of Henle. It's a potent diuretic and has some side effects like wasting different things like sodium and calcium and magnesium. It can cause hyponatremia, hypocalcemia, and hypomagnesemia. You obviously have a diuresis and are losing fluid, so you can have volume loss and hypovolemia. And interestingly, when you bolus Lasix for treatment for heart failure patients, one of the benefits is it venodilates even before you start diuresis. And if you venodilate and reduce preload to a failing heart, the heart says thank you very much, and it is a beneficial effect. So venodilation, Lasix, that's a side effect. Metabolic alkalosis, contraction alkalosis. If you have someone up in the ICU and you've been giving them Lasix every day for a week, it's not infrequent to see a metabolic alkalosis. Hearing loss, hyperuricemia, and potassium loss, very common. The next key word is magnesium effects. Where is magnesium used clinically? Well, in OB as a tocolytic and anticonvulsant, sometimes to treat cardiac dysrhythmias like torsades de pointes and digoxin toxicity, and occasionally in the ICU because hypomagnesemia is relatively frequent there. Magnesium has lots of effects, and I've listed some of them here. Works with enzymes in DNA and protein synthesis. It's a regulator or cofactor in like the sodium-potassium pump and adenyl cyclase and proton pumps. It does just the opposite of usually what calcium does, so it's called an endogenous calcium antagonist. Potassium metabolism is important. Magnesium has an important effect on it. Regulates the sodium-potassium ATPase, an enzyme that controls potassium entry into cells and potassium reabsorption by the renal tubules, especially in those who are potassium depleted. So if you're trying to replace potassium in someone and their magnesium is low also, you need to replace both of them. Magnesium influences the release of neurotransmitters at the neuromuscular junction. It has a presynaptic effect, just the opposite of calcium. And if you have large amounts of magnesium on board, you've given magnesium, for example, to a patient, you can expect prolongation of both non-depolarizing and depolarizing neuromuscular blocker agents. It blocks the release of catecholamines from adrenergic nerve terminals, and it actually antagonizes NMDA receptors similar to what ketamine does, a little different place, and has been used in chronic pain and pain management in some situations in research. So side effects of magnesium, if you give it as a bolus, they vasodilate. That's one of the very first things that you see, and commonly, and they can flush and even become hypotensive if you give a gram or two rapidly. Sedation, sometimes nausea, vomiting, muscle weakness because of that presynaptic effect of reducing calcium entry presynaptically, and increasing sensitivity also to non-depolarizers and depolarizers. So some toxicity signs of magnesium was the next key word. So let's look at the graphic at the far right first of the effects of increasing plasma magnesium levels. The normal being 1.5 to 2 milliequivalents per liter, and as the magnesium levels goes up, for example, up on the OB floor when it's being used as a therapy, you can actually start to have electrocardiographic changes such as interval prolongation of the PQ interval, QRS complex starts to widen, and then eventually the deep tendon reflexes go away. And that's one of the things that we monitor in patients who are receiving magnesium intravenously. Check their deep tendon reflexes. If they stop, if you lose them, you better stop the magnesium infusion. It's too high. And then you can see how the heart becomes affected at higher doses with block of the SA and AVE node. And then you stop breathing and you have cardiac arrest with very high levels of magnesium. Treatment, the neuromuscular and cardiac toxicity, we treat it acutely with IV calcium. If it's not very bad, saline and Lasix, and you can resort to dialysis if necessary to drop magnesium levels. The next key word is inhaled nitric oxide, mechanism of action. And let's look at the graphic and focus on it first, where you have oxygen and nitric oxide being inhaled down into the alveolus. Nitric oxide leaves the alveolus, and the capillaries right next to it goes into, raises cyclic GMP, and cyclic GMP relaxes the capillaries around that area. So you can see how nitric oxide would dilate the pulmonary vasculature in someone with pulmonary hypertension, and it's used to treat pulmonary hypertension and right heart failure. It improves ventilation to perfusion ratios. It's selectively delivered to very well ventilated alveoli and therefore dilates the blood vessels there, raising perfusion. It works through cyclic GMP, but why is it so short acting, and why just on the pulmonary vasculature? Because as it crosses the alveolus into the capillary and then into the blood, it binds to hemoglobin and forms a complex, nitrosyl hemoglobin, and therefore it becomes inactivated by the time it gets into the left atrium, left ventricle, and pumped out into the systemic circulation. It's no longer free nitric oxide and doesn't vasodilate the systemic circulation. So it's inactivated by hemoglobin, and it's rapidly metabolized to methemoglobin. Nitric oxide, can have an immunosuppressive effect. It can inhibit platelet adhesion and aggregation. And if you start nitric oxide 20 to 40 parts per million in a patient, don't just stop it rapidly if they've been on it, but usually will slowly reduce it, because you can get a rebound effect in pulmonary vascular resistance, an increase in pulmonary vascular resistance, and obviously the right heart would not like that. The next key word is NSAIDs and the renal effects. And let's look at the graphic on the right first, showing how prostaglandins can dilate the afferent arteriole and angiotensin can constrict the efferent arteriole, and this affects glomerular perfusion and glomerular filtration rate. We want those prostaglandins in that afferent arteriole to vasodilate and to improve blood flow to the glomerulus. And you can see on the far right that NSAIDs and COX-2 inhibitors can have an inhibitory effect on prostaglandin formation and therefore reduce afferent arterial blood flow in the kidney, reducing GFR. So blockade of prostaglandin-mediated effects of renal blood flow leading to acute renal insufficiency or even ischemic acute renal failure with retention of fluids and retention of solutes can be a problem with NSAIDs. In the elderly, critically ill, patients with heart failure, bad kidneys or liver, especially at risk, and production of renal dysfunction with NSAIDs is more likely in people that are really old, if their kidneys are already not working so well, they're hypovolemic, they're septic, undergoing major surgery, or have other risk factors for acute renal failure, and therefore NSAIDs are avoided in those patients. So when you're thinking about giving like ketorolac, Toradol to a patient that's very old or has not great kidneys already, or they're hypovolemic, you're going to think twice about doing that. Other renal effects of ketorolac include loss of protein in the urine, interstitial nephritis, papillary necrosis of the kidney, and we don't give it for an extended period of time to patients in the perioperative period. The next key word is digoxin toxicity and the treatment of such, and the EKG at the top with the blue arrow shows dig effect. Dig effect on the EKG is curved ST segment depression and flattening or inverted T waves and a short QT interval. So all across the EKG you see that scooping or dig effect. Why is dig used in patients anymore? Well, it's still occasionally used to treat atrial fibrillation to control the ventricular rate, slow the AV nodal conduction, and occasionally in patients with heart failure, although it's not a great inotrope. Dig inhibits the sodium-potassium ATPase and increases intracellular calcium in myocardial muscle. Dig toxicity, if you're taking too much dig, what are some of the risk factors for having toxic effects? If your potassium or magnesium are low, it's going to potentiate the chance of having toxicity. And the way it presents, patients get nauseated, they start to vomit, they see weird color disturbances, I believe it's yellows, ventricular premature beats and bradycardia, AV conduction is affected, even VTAC and VFib, and that classic dig effect all across the electrocardiogram, the ST segment depression and changes in T waves. And the treatment is digoxin-specific antibody or dig immune antibody, Digibine. And that binds the digoxin actually and inactivates it very rapidly. We can also use magnesium and dilantin and lidocaine to treat arrhythmias of dig toxicity until an antibody becomes available. The next key word is organophosphate poisoning and the diagnosis of such. Organophosphates are present in insecticides. Nerve gases like sarin nerve gas also act in the same place as these organophosphates, which is inhibiting acetylcholinesterase. They are anticholinesterases, and they poison that enzyme. Well, if you poison the enzyme that's breaking down acetylcholine in that postsynaptic, the cleft in the postsynaptic junction, what's going to happen? Acetylcholine is going to go up very high levels, and you're going to get muscarinic side effects. Bradycardia, slowing of the heart rate, bronchoconstriction, small pupils, urination, defecation, vomiting, and eventually you get so much acetylcholine you get almost like a succinylcholine-induced flaccid block, and they get muscle paralysis. So the treatment, if there's too much acetylcholine around, is block the acetylcholine with atropine, a competitive muscarinic blocker. And in the case of nerve gases, pralidoxime has been used in an attempt to reactivate acetylcholinesterase enzyme by removing the organophosphate compound. May not be as effective as we used to think. And then pyridostigmine is actually used by people who anticipate being exposed to a nerve agent. So if a person was in Iraq, for example, or some other previous war zones, where they thought they might get exposed to a nerve gas, they can take pyridostigmine before they are exposed, and that seems to like cover that cholinesterase enzyme and protect it so that it doesn't get inactivated by the nerve agent. So a gap in knowledge in 2019 was nerve gas treatment. So let's just briefly talk about that as we talk about poisoning of the acetylcholinesterase enzyme. Prophylaxis against nerve gas treatment, we talked about pyridostigmine, and on the far right you have it being shown as a pill being opened and you take. It's reversible inhibition of the acetylcholinesterase active site. It protects it from irreversible inhibition by the exposure to the nerve gas that occurs later. It doesn't cross the blood-brain barrier, and it is not a treatment for acute toxicity, which atropine is the immediate after exposure treatment. And here is that soldier giving themselves an injection right through their covering, and the anticholinergic atropine blocks the acetylcholine effects, antimuscarinic, and the addition of pralidoxime, which may reactivate the enzyme, although somewhat controversial, is still part of the treatment for nerve gas. Others treatment, benzodiazepines can be used to treat the seizure and the excitation that can occur with a nerve gas toxicity. Our last key word is tramadol or Ultram and its mechanism of action. Tramadol is a mu receptor agonist like opioids, but it also affects serotonin and norepinephrine levels. And let's look at the graphic on the far right, focusing at that presynaptic neuron and looking at the three red stars. Reuptake and inhibition of norepinephrine is one thing that it does. So norepinephrine levels go up. Its reuptake is inhibited, so norepinephrine concentration rises. The top right, you can see that serotonin reuptake is inhibited, so serotonin goes up. And then in the postsynaptic neuron, the third star, you can see the mu receptor, and that is where tramadol is also working. So unlike opioids, which tend to work on mu1 receptors, now we have tramadol that works on the mu receptor, but also increases serotonin and increases norepinephrine. So if you have a drug that is increasing serotonin by inhibiting its reuptake, any other drug that inhibits reuptake of serotonin, like SSRIs or drugs that raise serotonin levels, can cause a serotonin syndrome, which can be associated with rigidity and hyperthermia and look very much like MH. And it can be treated, the serotonin syndrome, with benzodiazepines and a serotonin blocker called cyproheptadine. Serotonin syndrome is a risk with tramadol. Now, MAOIs, or monoamine oxidase inhibitors, like phenelzine as an example, are occasionally used in patients with intractable depression, Parkinson's disease, and other areas, used in psychiatry occasionally. And if someone was on one of those and you gave them tramadol, you can see how they could get serotonin syndrome. Tramadol is a prodrug like codeine. It has to be metabolized by the CYP2D6 syndrome enzyme, that is, to an active agent, an opioid agonist. Tramadol, its mechanism of action. This is the end of a two-part review of keywords from 2020 American Board of Anesthesia published keywords, and I hope you have a wonderful day. These pictures are some challenges and some beauty that I found in France 2019, cycling up the Col d'Iseran in the snow, and at the top of Col de Galibier, a snowstorm, but it was beautiful. I wish you the very best.